The Allergy Foundation of South Africa, Atopic Dermatitis. This short video has been designed to give you some information about atopic dermatitis, more commonly known as eczema. It is by no means comprehensive, but will hopefully increase your understanding of atopic dermatitis and its management. What is atopic dermatitis? Dermatitis refers to inflammation of the skin. The word eczema and the word dermatitis can be used interchangeably. However, dermatitis tends to be used by doctors and eczema by lay people. There are many different types of dermatitis. Atopic dermatitis is a specific form of dermatitis named because of its strong association with atopy, the tendency to have allergic diseases. What causes atopic dermatitis? A number of factors work together to cause a person to have atopic dermatitis. These include genetics, environmental factors, and the immune system. These factors interact to produce a defective skin barrier, which is the core problem in atopic dermatitis. The skin barrier can be understood as similar to a brick wall, with structural elements of the skin holding the bricks or skin cells together. The oily secretions produced by the skin seals the gaps between the bricks as a type of cement. Individuals with atopic dermatitis, which we'll sometimes refer to as AD, have an abnormal skin barrier, which results in breakdown of the skin and an increased loss of water from the skin. This not only allows the loss of water, but also the penetration of irritants and allergens into the skin that may result in inflammation. How common is AD? AD is common and on the rise in developing countries. It has a characteristic appearance and changes in distribution on the body and face as the individual ages. Atopic dermatitis is not a mild disease. It can have profound effects on quality of life. It can result in intractable itch and sleep deprivation, with secondary effects on behavior and learning. Complications such as infection and scarring may arise. It causes negative effects on family life and absenteeism from school and work. Many patients experience teasing by peers, resulting in low self-esteem. The prognosis of atopic dermatitis is, however, quite good. It has a tendency to improve at 3 to 5 years and in many people resolves during their teens. The features of eczema. Itch is a cardinal feature of AD. AD is described by some as an itch that rashes. This highlights that the dry skin causes the itching which precedes the rash. The trauma of scratching may contribute significantly to the inflammation. The scratching is often subconscious and extremely difficult or impossible to control. Scratching may break the skin, making it susceptible to infection. Skin care. Patients should avoid irritants such as coarse clothing, fragrant skin products, bubble bath, etc. Pay attention to skin hygiene and care. Focus on itch prevention by avoiding hot bedrooms, cutting nails, avoiding woolen and other rough, scratchy clothing, and avoiding overdressing. It is critical that soaps are avoided as they dry out the skin, and that a suitable soap substitute, aqueous cream, emulsifier, HEB, cetomacrogol or similar, is used. Avoid harsh washing powders and do not use any fabric softener as it adds extra chemicals to the clothes. Consider using bath oils in the bath. Emollients are oil-based topical preparations that are effective for restoring skin barrier function in AD. Emollients should always be used even if the skin is clear. Restoring the barrier dysfunction by plastering a layer of emollient on the skin is the most effective maintenance therapy for AD. The problem is that this plaster gets rubbed off the skin and is only effective for a few hours. Patients with severe AD are usually advised to use an emollient as often as possible, preferably 6 to 8 times a day or more. Emollients work. Notice how the bridge of the nose remains clear even in severe AD, such as seen in this picture. This is due to the natural moisturizer produced by the skin glands in this area. The same can be achieved by using sufficient emollient. Treatment. Additional therapy may be needed to avoid or treat flares, that's the worsening of AD lesions. The most commonly used treatment for flares are topical steroids, which have an anti-inflammatory effect. Topical steroids come in a range of strengths or potencies that range from mild to very potent. Overly frequent use of topical steroids or using too potent topical steroids may produce skin that is very thin or has an altered color. Note that the use of topical steroids should be guided by a healthcare practitioner. Another option is the early or maintenance use of topical calcineurin antagonists, such as Protopic or Elidel. They are less potent than steroids and have very few side effects, although they may cause transient burning. They are useful for sensitive areas like the face, neck, and in skin folds. Application of wet wraps. A popular strategy for acute flares is the use of wet occlusive dressing. Wet dressings aim to reduce the itch, cool and soothe the skin, moisturize the skin, and allow deeper penetration of emollients and active ingredients, protect the skin by preventing access to scratching, and promote sleep. They are often used overnight. Various commercially available suits can be purchased, or light cotton underwear or pajamas modified for wet dressings. In the state service, we use tubular bandages of various sizes to construct homemade wet wrap suits. The stages of dressing someone starts with washing with soap substitute. Then tubular bandages of various sizes are selected, measured, and cut. After bathing, the skin is gently patted dry. The appropriate steroid is applied to the affected areas as advised by a healthcare practitioner. The emollient ointment is then applied smoothly, rubbing in the same direction as the hair follicles, not against the grain. Then, a layer of wet wraps dipped in water and then wrung out is applied, followed by a dry layer aimed at covering as much of the affected skin as possible. Food allergy and atopic dermatitis. A minority of those who have AD also have food allergy. This is more likely in those with severe AD. However, it is far more common for AD to be the precursor to food allergy rather than food allergy causing eczema. Food should not be removed from the diet for treatment of AD without the guidance of a healthcare practitioner. Thank you. Be sure to visit the AFSA website at www.allergyfoundation.co.za for further information.